So this is a 76-year-old patient who was referred for a colonoscopy due to weight loss. During the first colonoscopy 2 weeks ago, there was a resection of 5 polyps with a piecemeal EMR of a bigger polyp, 25 millimeters, with a piecemeal EMR on the hepatic flexure. But in the transverse colon, there was a lesion which was difficult. It was a non-granular polyp, very flat, but it was non-lifting. So it didn't lift after injection. It was about 15, max 20 millimeters, but it did not lift. So he was referred for a second referral for a second try today to assess the lesion. Is it malignant? Is it non-malignant? It didn't look malignant then, but we will check it now. And see if it can lift or not.
All right, so why don't you start the colonoscopy? We've divided the procedure here because so we're talking about the experience of Thibaut is more than the experience of, what's your name? Julie. So Julie's experience is much less than Thibaut. So we agreed for Thibaut to do the colonoscopy, go to the lesion, assess it. If we think it's resectable, then we will make a start with EMR technique with Thibaut. And then other lesions would be for Julie to do. And if necessary, we put her on another case because this case is too challenging. But I mean, this is a classic situation, right? We've talked about it already, where you find a polyp on your resection, on your non-resection list, on your screening list, or on your symptomatic list. You've assessed it, and as Florence has done, she has made an assessment of whether she thinks that this is resectable or not. She has thought that it's resectable, and so she sent it for further assessment. So next thing, is it a target for cold snare polypectomy?
Well, it's not, because it's more than 10 millimeters. It's not a sessile serrated lesion.
Perfect. You can stop there. I agree with you. The evidence base runs out when you say it's not a sessile serrated lesion. There are some people you will find resectomies with cold snare, but that is not evidence based, and it is outside the remit, or it should be performed within studies. Okay, so you've decided snare polypectomy. You've decided hot snare, and now the next question is, and this is the decision-making tree we're doing. In one piece or in multiple pieces? And what is the justification for your answer?
Well, I think you could do it on block, but this brings about a high risk of deep neural injury, perforation. And
so wait 1 second. That is a great answer. So what he's just said is this could be done on block. It certainly could be done on block, but it brings with it an increased risk of deep neural injury or perforation. It brings with it an increased risk of intra-procedural bleeding, and it brings with it an increased risk of delayed bleeding, i.e. the patient going home and then coming back to the hospital with bleeding. That is exactly right. And there is evidence to support that. If you want to know what it is, we'll direct you to the article that nicely demonstrates that. So actually, what we're saying is, because there is a low risk of cancer within this lesion, it is acceptable to do this piecemeal. Is that what you're thinking?
Yeah, for sure. Yeah, it brings about it brings about less risk if you do it piecemeal here.
Okay.
We don't think it's malignant. It's JNet 2A probably. So.
Well, no demarcation zone, so we're not so worried about that. But okay. So let's talk about a plan, John. Have you got some advice for Thibaut regarding a plan for this lesion?
So you need to consider where the potential pitfalls are here. So I can see a few myself. So Thibaut, what's going through your mind in terms of where there's potential difficulty, and importantly, I'm assuming you're going to lift it, and if you're going to lift it, where are you going to put your injection and why?
So possible problems I'm foreseeing here is the fluid pool. It's probably gonna annoy me after a while. Maybe it's not at 6 o'clock yet, so it's not the perfect positioning yet. It's non-granular, which makes it harder to do the piecemeal EMR. Of course, the history that it was non-lifting before makes it harder for me this time, because there might be some tissue reaction already, because the lifting itself might be difficult because my colleague also already tried, and so it may be a difficult lifting. So these are the things I can already foresee that can be possibly be difficult.
Okay, so the other thing I'm thinking is you've got a main dominant fold currently running across the screen from 10 to 6, then you've got the lesion and it sort of sits in over another fold, and you run the risk of making the access more difficult. So you are right, you need to take the lesion and bring it round to sort of 5 or 6 o'clock, and then your injection, if it was me doing this, particularly potentially having a non-lesion, your initial injection, non-lifting lesion, your initial injection on this occasion needs to be on the oral side of the lesion. Or if you think it's benign, you may want to use the very back edge of the lesion to take some of the needle, because when people have non-lifting, it can be their injection technique rather than the polyp, and you might find the polyp lifts very nicely if your injection technique is correct. But I'd be very careful about where you put the first injection so you make the resection easier, not more difficult.
And we have now found another non-granular lesion in this patient, right? That wasn't detected the first time. I mean, Roland made the great point about should you look at the colon again? Some things prompt me to do so, and that's one of them. We know that non-granular lesions are not often on their own. They're often multiple. They're very, very easy to miss.
And one of the reasons for that is if you look at the end of the endoscope, you have two eyes, which are the lights and what you're seeing, and then you have the accessory channel, which sits down here just off the center. And you want everything at the bottom, so you're looking down at what you can see. And then your accessory, you can see your accessory. If you have the lesion up here, your accessory is coming across the front of your screen and will occlude the view, which is why we need it down at the 6 o'clock position.